Welcome to all the trainees present all over the world who logging into this YouTube channel to get some idea about the urology exam preparation. Today we are going to discuss few stone scenarios and we got a trainee who has kindly agreed to record the session so that it will be a good learning and revision resource. The scenario starts now. You got a 35-year-old female presenting with left-sided loin pain in A&E. The urine dip showed presence of 1 plus blood and 1 plus leukocyte. The symptoms are quite characteristic of left urinary colic and hence the A&E consultant has directly rang you. What will you do?
Okay, so I would recognise that this is a potential urological emergency and attend to see the patient at my next available opportunity. I'd begin by assessing the patient's physiological status, checking their observations. Are they parexial? Are they tachycardic? Do they have any other signs which might be a sign of sepsis? We go on to take a brief history from the patient. So I would ask when the pain commenced, the character of the pain, does it radiate anywhere? Is it associated with any infective symptoms or lower urinary tract symptoms? And has the patient been systemically unwell in the days preceding this presentation with vomiting or general systemic upset? I would also ask about a brief medical history. So is the patient pregnant, or have they had recent urinary tract infection? Have they had recent antibiotics? Do they have any medical history which they take regular medications for? Do they have a personal or family history of stone disease? And then with verbal consent, I would undertake a chaperoned examination, beginning with the general examination of the patient. Are they uncomfortable from the end of the bed? Do they look unwell? I would examine the abdomen for a palpable bladder or palpable kidney. And then I would undertake a brief, some baseline bedside investigations, including blood tests of full blood count, renal function and CRP, and I would assess the urinalysis result, which you say was positive for non-visible hematuria and leukocytes. Based on the information I have, my concern is that the patient may have an obstructing ureteric calculus, in which case the next step would be to adequately analgese the patient with pain relief, preferably non-steroidal analgesia, and then following a pregnancy test, arrange a CT KUB.
Okay. The patient is quite unwell for the past few days as vomiting and not able to tolerate any oral feeds. Otherwise, quite tired and no other systemic illness in the past. And examination also for you convincingly left ureteric colic. I will try to share the picture so that you can run through them. Are you able to see the picture?
It's just started sharing. Yeah, I can see it now. Yeah.
So can you read this X-ray for me?
Yeah. So this is X-ray KUB, which demonstrates there appears to be a calcification in the pelvis. You can't say 100% whether it's a phlebolyth or a ureteric calcification, but there's a calcification on the left side in the pelvis. And from this image, there's a faint calcification in the zone of the mid-ureter, around just at the left side of L4, which could also be a calcification.
Okay, so what is your next step?
So this is an X-ray KUB, so I'd like to arrange a CT KUB to look in more detail.
Okay, so this is a CT KUB. I'm going to run it from top to bottom. You can stop me whenever you want. So that's the top.
Okay.
It's a good habit if you start narrating as the examiner.
Okay, fine. So, yeah, this is an axial film of a non-contrast CT scan, currently evaluated the abdomen. There appears to be some dilatation of the left collecting system, with the right side appears to be a normal and non-obstructed kidney. And then we're just moving down. The left ureter is dilated with some associated periureteric stranding and edema. We're still following down now into the pelvis. And yet the left side appears to be, the left ureter appears to be edematous all the way down and remains dilated. So my concern is there may be a distal obstruction. Yeah, and then there's a calculus in the region of the left vesico-ureteric junction, consistent with an obstructing ureteric calculus with proximal dilatation.
Okay, good. So what will you do?
So my concern from the history is that the patient is unwell, showing signs of systemic upset. They may be demonstrating early signs of sepsis. I'm worried that they may have an infected, obstructed left kidney, which is a urological emergency. So the next step is to initiate Sepsis 6 protocol, ensure that full blood tests have been taken, including a lactate and blood cultures and urine cultures. I'd also arrange for the patient to be commenced on empirical IV antibiotics in accordance with local formulary, given IV fluid resuscitation, and also catheterized with hourly output commenced. My concern is that this lady has an infected obstructed kidney and needs de-obstruction in the form of either nephrostomy or a retrograde stent. If there are no contraindications, my plan would be to arrange for an urgent anesthetic assessment and for the patient to undergo a retrograde ureteric stent in emergency theatre.
Okay, so definitely this patient has got left side hydroureteronephrosis due to the stone in the left VUJ. The stone measures around 7 millimeter, and apart from the weakness and the vomiting she had for the past 2 days, her ops were absolutely normal. No signs of any temperature and no signs of any sepsis. Will it change your approach?
Okay, so if there are no signs or concern of sepsis, then that would change the situation. With a 7 millimeter VUJ stone, there is a chance that the stone will pass spontaneously, although it's less than 50%. So I would give the options to the patient. I think the most important initial management is to manage her pain relief. So ensure that she has had. My practice would be to give 100 milligrams of PR diclofenac. Can also give oral dihydrocodone or supplementary oral Oromorph if required. Give antiemetics to treat her nausea and vomiting. And then lay the options out to the patients. The options are either a trial of conservative management, which with a 7 millimeter distal ureteric stone could be also given with medical expulsive therapy in the form of tamsulosin in accordance with EAU guidelines. If the patient's pain is refractory or there's evidence of renal dysfunction, then a retrograde stent could still be considered as an emergency temporizing solution. And then definitive management would be either a primary ureteroscopy during the admission or extracorporeal shockwave lithotripsy if there is access to that in my unit. But that will depend on how the patient develops in the next 24 hours.
Okay, explain the various medications available for medical expulsive therapy.
Okay, so the EAU recommend tamsulosin in distal ureteric stones greater than 5 millimeters, and NICE recommend the same treatment but in stones under 1 centimeter, distal stones. So the dose is 400 micrograms once daily, and the theory is that this will relax the smooth muscle in the ureter and assist in spontaneous stone passage. Previous treatments for medical expulsive therapy included calcium channel blockers such as nifedipine, although these are no longer recommended in the guidelines, and recommended analgesia as non-steroidal analgesia in the first instance. Yeah.
Okay, and you need to mention that even though the NICE and EAU guidelines recommend tamsulosin, it is still not licensed for this purpose, that too in a female. So you need to mention that the prescription is unlicensed.
Okay.
Okay, and you are giving her diclofenac, and how are you going to review her again? When you will review, and what's your strategy?
Yeah, so this patient's still in the emergency department at present, so I would admit the patient to the urology ward, ensure that she's adequately analgesed, commence medical expulsive therapy, and explain that this is an off-label prescription. And the patient would need to be reviewed on a regular basis during the initial few hours of admission, check whether there's been a response to the analgesia, whether she's developing any worsening pain or signs of sepsis, in which case emergency treatment might be indicated. If the following day her pain is controlled and she remains physiologically well, it would be reasonable to discharge with a plan for interval X-ray in 4 weeks to evaluate for spontaneous passage. If her pain remains significant, then we can consider primary treatment options, either lithotripsy or ureteroscopy, or a retrograde stent insertion.
Okay. What are all the literature to support or refute your concepts of medical expulsive therapy?
So, medical expulsive therapy is a somewhat controversial strategy. There are two papers which had differing conclusions. So the SUSPEND trial, published in 2015, randomized patients to either nifedipine, tamsulosin, or placebo, and followed them up for 28 days. And if there was no requirement for treatment, they deemed that as evidence of spontaneous stone passage. And this paper concluded that there was no role for medical expulsive therapy, either tamsulosin or nifedipine, as there was no difference in spontaneous passage in these groups compared with placebo. However, the following year, a paper published by Furyk et al. Randomized patients with distal stones under a centimeter to either tamsulosin or placebo, and found that there was a significantly higher spontaneous stone passage rate in those given medical expulsive therapy, with a number needed to treat of 4.5 to successfully pass a stone. And in the most recent EAU guidelines and NICE guidelines, they do continue to advocate medical expulsive therapy in patients with distal stones greater than 5 millimeters in diameter on this basis.
Okay. Is there any role for medical expulsive therapy for upper and mid-ureteric stones?
The guidelines suggest that it is beneficial in distal stones.
Okay. Now, you're reviewing this patient in 4 weeks' time with another up-to-date X-ray. There is no change. It's exactly as it is. And patient's symptoms are slightly better, but she still has episodes of vomiting once in a week. She is feeling better mainly because of the diclofenac and other analgesics.
Okay. So the data suggests that stones are unlikely to pass beyond 40 days. So if we take into account that this patient had pain for a few days prior to admission and then was followed up 28 days later, they are unlikely to pass the stone spontaneously at this stage. Therefore, we would discuss treatment of the stone with either, in EAU would advise that ureteroscopy is the best approach for distal calculi. Although lithotripsy would also be an option, and both options would be discussed with the patient.
Okay, you said lithotripsy for the VUJ stone. How will you approach? What challenges you may come across?
Yeah, so distal stones are not ideally treated with lithotripsy because there is the view is hindered by a pelvic bowel gas, but the success rate will be slightly lower than if it was an upper ureteric stone. It would also depend on success rate. Would also depend on the stone composition and stone density on imaging. A ureteroscopic approach would be preferable, and would be the approach that I would advocate to the patient based on our guidelines and experience.
Okay, you are listing this patient for ureteroscopy. She is attending, and today is the day of the surgery. How are you going to approach?
Okay, so on the day of surgery, I would begin by assessing whether the patient is still happy to go ahead with the procedure that we had previously discussed. Using the BOUS patient information leaflet, I would consent the patient advising that the procedure would be undertaken under a general anaesthetic, would involve insertion of a ureteroscope via the bladder and a laser used to fragment the stone and remove the fragments, which would then be sent for analysis. I would advise that it may be necessary to insert a ureteric stent, although this will be avoided unless absolutely necessary. And complications would include discomfort after the procedure, hematuria, infection, which would be a risk, but the risk reduced by giving prophylactic antibiotics, requirement for a stent, and then a small risk of further procedure or injury to the bladder or ureter during the procedure. And then, following appropriate consent, we would proceed with the operation.
What prophylactic antibiotics you prefer for ureteroscopy?
So our local guidelines would advise a single dose of IV gentamicin, unless there's any contraindication to that or patient allergy.
What could be the dose?
We would give a dose of 4 milligrams per kilo as a prophylactic dose.
Okay. So what kind of ureteroscope you're going to choose for her?
So with a distal ureteric stone, I would advise using a short semi-rigid ureteroscope with a 273 micron laser fiber.
Okay, so what is your approach? Take me through. Patient is prepped, anesthetized,
Okay.
consented, in position for you.
Fine. So with the patient appropriately positioned, consented, and the WHO consent checklist completed, and with antibiotic prophylaxis, I'd position the patient in the lithotomy position, begin with a rigid cystoscopy, insert a sensor guide wire to the left pelvic ileocecal system under fluoroscopic guidance, and then alongside the safety wire, I would pass a short semi-rigid ureteroscope to the level of the stone, and then use a 273 micron laser fiber and a holmium laser to dust the stones with a high frequency, low energy setting, such as 10 hertz and 0.5 joules, and use either a zero tip or an N-gauge basket to retrieve the stone fragments and send them for metabolic analysis.
Okay. And how this laser works on a stone?
So holmium laser, in the context of lithotripsy, works in a photothermal mechanism whereby a shock wave is essentially created, which initially creates microfractures within the calculus, and then creates micro bubbles which expand and disintegrate the calculus. Has a penetration depth of around 0.4 millimeters and is absorbed by water, so is deemed to be safe within the ureter with low risk of urothelial injury. And it works depending on the laser settings, it works by either dusting or fragmenting the stone.
Okay, what do you mean by dusting and fragmenting? What's the difference?
So using a high frequency, low energy setting, the stone is dusted into almost microscopic fragments, whereas fragmentation uses a low frequency, high energy setting to break the stone into larger fragments, which are then removed individually.
So how will you decide whether to dust or fragment in a patient?
So it depends on a few factors. So it depends whether on the size of the stone. If it's a large stone in the renal pelvis, then dusting would be preferable. If it's a small to medium-sized stone in the ureter, then it could be fragmented with removal of individual fragments. But it would depend on the stone composition, the stone location, and whether fragments are to be sent for analysis.
Does the stone hardness decide your pick of the energy source?
Yes. So hard stones, for example, calcium oxalate monohydrate stones, they would require higher energy to fragment or dust, whereas softer stones such as uric acid stones would require minimal energy.
Okay, so harder the stone, it's better to fragment rather than dusting, and sometimes dusting won't work if the stone is hard.
Right.
Okay, so you managed to dust the stone which is in the left lower ureter. and stone seems to be nicely dusted, no significant residual fragments visually seen. What is your exit strategy?
Okay, so if this has been an uncomplicated ureteroscopy with complete stone clearance, then I would not insert a ureteric stent. I would retain the fragments, send for analysis, empty the bladder, and conclude the operation. I would explain to the patient post-operatively that the operation was a success. They may experience some colic-type pain for the next 24 to 48 hours, and that the stone fragments would be sent for analysis. We would follow the patient up, normally with an ultrasound scan in 3 months, plus or minus an X-ray KUB to exclude residual fragments. And if this is a first episode of urolithiasis and they don't require any specific follow-up and analysis, but we would advise general measures, including increasing fluid intake to reduce risk of recurrence.
Okay. Her ultrasound and X-ray KUB reviewed during the follow-up was completely clear. She's quite asymptomatic. The stone report came as calcium oxalate monohydrate. Does this make any difference, or what advice you will give?
It wouldn't. I mean, if this is the first episode and it's a calcium oxalate monohydrate stone, that is a common stone to form. The general measures I'd advise would be increase fluid intake, maintain a normal calcium intake, reduce salt intake, reduce protein intake. And if the patient was to form a second stone, then that may influence the preventative strategy.
How the reduced salt and protein intake works?
So high salt intake results in hypercalciuria through the co-transport of sodium and calcium within the renal tubule. And high protein diets can acidify, so the purine content acidifies urine and puts patients at high risk of uric acid stones.
Okay. So are you going to discharge her, or what's your follow-up strategy?
So if the procedure, if she's made a unremarkable post-operative progress, I would discharge the patient either same day or the following day. In most cases, day case uncomplicated ureteroscopy is a reasonable strategy. Follow the patient up with ultrasound and KUB, as we've said, and then I wouldn't routinely follow up the patient beyond that for a first episode.
Okay, good. I'm quite happy with this. The scenario is complete now. Do you have any questions before we conclude the scenario?
No, I think it was okay. A couple of things, I guess, and maybe I guess at the start, I assumed that this was a kind of sepsis picture when you said vomiting and severe pain. Maybe jumped into that a bit too quickly. Sorry.
Yeah, slightly too much and too quickly, as you said, because there is a hydronephrosis that's quite expected. The periureteric strangling, what you identified, is there, but it's not that significant. But maybe jumping into that before that, you can just check to make sure that nothing wrong in getting a SOFA score, so that you know about the scoring, and then you can decide based upon examiner's input, okay, she's not scoring, so she's not a septic patient, so I will go ahead with primary ureteroscopy. They based upon the facilities. Yeah, quite straightforward. You are able to bring some evidences for and against the MET. That's the main crux of this scenario. I have no concerns. Okay.
Okay, that's great. Thank you.